Good evening, everybody. Welcome to this live webinar from the European Society of Gastrointestinal Endoscopy. And this evening, we're going to be addressing a very interesting question about the diagnosis and management of pancreatic neuroendocrine tumors, or NETs for short, sometimes neuroendocrine neoplasms or NENs, what every endoscopist needs to know in 2022. My name is Dermot O TOOLE. I'm a gastroenterologist and a NET specialist working in Dublin, in the Centre of Excellence, an ENET Centre of Excellence, and of also representing the European Neuroendocrine Tumor Society. We will also be welcoming Professor Ulrike Denzer as the second talk, and she's from Marburg, and Dr. Vicente Lorenzo-Zúñiga from Valencia. Thank you very much for joining us, and we look forward to a very interactive session. Don't hesitate to send through questions as we go along. Just a few housekeeping notes. The first thing to say is that ESGE will be having its annual meeting, ESGE Days, next year in April 20th to 22nd, and very glad and proud to have this event coming to Dublin. It's a hybrid event. Registration opens on December the 1st, so please join us. There will be abstract submission deadline for December the 6th, and the host society is the Irish Society of Gastroenterology, and we really look forward to welcome you all to Dublin for this event. The benefits for the abstract submitters are numerous. Top 4 abstracts feature in the opening session. There are travel grants awarded to the top 40 submitters, 40 years old and younger. Publication in Endoscopy, which is an impact of 10.4, which is the highest dedicated GI endoscopy journal impact. And we have in 2023 something exciting, a new best case reports that will be judged on site. And we also have a lasting international exposure for your research. Some of the program highlights include the ISG symposium taking place on the first day. We have state-of-the-art lectures on basic and cutting-edge endoscopy. There is a forum on artificial intelligence and third space endoscopy, and therapeutic EUS and EOCP. We've got latest updates and guidelines and position statements, and 2 different leading centers joining us live from Hamburg and London. So very exciting, up-to-date and live sessions. Also networking opportunities with experts in endoscopy, postgraduate course discussions, and hands-on training sessions as well. So hopefully you will join us for this very exciting meeting. So back to this evening then. What we decided to do was to discuss the diagnosis and management of pancreatic neuroendocrine tumors. And I'm going to give an overview first on the general aspects of pancreatic neuroendocrine tumors, because as endoscopists, of course, we need to know a little bit about the broader spectrum of how these tumors, even though they're often very small, the ones we fit into, not always small, of course, we're making diagnosis, but the general aspects that you may not all be aware of with respect to pancreatic neuroendocrine tumors. I've no direct conflict of interest with this talk. So I'm going to talk then about some general remarks about pancreatic neuroendocrine tumors, or PNETs for short, a little bit about the epidemiology and biology, and some pertinent questions that will be relevant for the future speakers. How aggressive should we be for small, incidentally found PNETs? Should we think about limited versus more radical resections, and special considerations such as multiple endocrine neoplasia and other hereditary aspects? So if we look at neuroendocrine tumors, they're a diverse group of malignancies and a wide spectrum arising from neuroendocrine tumors cells scattered throughout the body, as depicted in the orange in this cartoon, from the lungs, from the stomach, from the intestine and colon, and of course from the pancreas. And the ones we're interested in this evening are the pancreatic neuroendocrine tumors, formerly called islet cell tumors. And these can be comprised of functioning tumors, resulting in specific symptoms from secretion of hormones or peptides, such as gastrin for gastrinoma, insulin for insulinoma, glucagonoma, VIP, somatostatinoma, and even pancreatic polypeptidoma, although I don't think the latter one really constitutes a specific syndrome per se. So these are really special circumstances where patients have specific functioning syndromes. They're quite rare. Much more common now are the non-functioning tumours that are often incidentally found. And on the other side of the slide, we've got the tumours coming from the other organs, but we're focusing tonight on the pancreatic neuroendocrine tumours. The vast majority of these tumours are indeed sporadic, but in a subset of pancreatic neuroendocrine tumours, they do integrate within a genetic predisposition syndrome, such as multiple endocrine neoplasia type 1, von Hippel-Lindau, or an NF1. We need to, especially with MEN1, keep this in mind. The incidence of neuroendocrine neoplasms in the gastrointestinal tract are increasing as they are in the lung, and this also is reflected in the incidence of pancreatic neuroendocrine tumors. And we can see also that localized and regional distant and unstaged disease is increasing in frequency as well. So it's not just the earlier detection of incidental tumors that explains the overall increased incidence, although this does make up a reasonable portion of patients as well. Some of the other important things to know about the various neuroendocrine tumors, including pancreatic, are that they have similar histological morphologies. And of course, the morphology is really important, how it looks under the microscope as being well differentiated. And of course, on the other spectrum, we've got the poorly differentiated tumors that are very aggressive, resembling more ordinary pancreatic exocrine carcinomas than neuroendocrine tumors. But the well-differentiated tumors stain for chromograninase, synaptophysin, and specific cytokeratins as well. And they often have this trabecular network. The other important thing about these is that the vast majority of well-differentiated tumors are hypervascular. This gives a clue to diagnosis. It's important also for endoscopic ultrasound diagnosis, etc. But also the presence of hypervascularity within these tumors is also a clue to how they behave. The more well-differentiated tumors tend to be hypervascular, and as we lose the vascularity, they tend to become more intermediate to poorly differentiated in grade as well. So this is interesting, and sort of as the spectrum of vascularity decreases, as we lose the markers for vascular patterns such as CD44 or VEGF, we find tumors that more resemble the behavior that we see in pancreatic exocrine carcinoma. And the other important thing that's really unique to pancreatic neuroendocrine tumors and other endocrine tumors of the gastrointestinal tract is the overexpression of somatostatin receptors. And this is very important when we come to staging and sometimes even detecting very small tumors of the pancreas or the duodenum, such as small PNETs or neuroendocrine tumors as part of MEN1. This is just to remind people of the nomenclature in terms of the World Health Organization classification. And we have basically the differentiation, which is well differentiated and poorly differentiated. We also have a mixed group of well or poorly differentiated integrating within tumors that are exocrine or mixed, so-called MIN-N. We normally are dealing with well differentiated tumors that tend to be of lower grade, with a Ki61 of less than 20%. We call the grade 1, they're less than 3%, Ki67 overall. Grade 2 would be 3 to 20%, and grade 3 is greater than 20%. And all of the poorly differentiated tumors, in fact, are grade 3, but some of the tumors between 20 and 50%, for example, or 60%, may have a morphology that looks like a well-differentiated tumor with a higher tumor grade. The biological behavior of those patients, in fact, their tumors within these patients tends to be more aggressive, and we need to be careful with those. With respect to diagnostics, I'm not going to go through this, but Ulrike will talk about this later. We use now contrast-enhanced CT scan, which is very, very good, as well as contrast-enhanced MRI. Very important also considered diffusion-weighted imaging, and perfusion scanning using either CT or MRI is also very valid. Endoscopic ultrasound and contrast-enhanced, we'll see that in a little while. But I think that we often will be confronted with a patient with a hypervascular lesion or a well-defined lesion in an asymptomatic patient. That's the sort of classical scenario we see more and more. And we are then going on to perform either an endoscopic ultrasound and biopsy, and we'll come to that in the next talk. However, pancreatic neuroendocrine tumors, like I said, really does have an important adjunct diagnostic and staging tool, and that is the use of somatostatin receptor imaging. And before we had imaging using indium, such as octreotide scan, this has all been surpassed now by the use of gallium somatostatin receptor imaging, so PET-CT, with DOTA-take or DOTA-knock or DOTA-talk. This is an example of a very small tumor that is very well visualized here on the right-hand side with a DOTA-take PET-CT. And this is really important for adequate staging. As you mentioned, the incidence of pancreatic neuroendocrine tumors are increasing, and it's not only the small incidental, less than 2 centimeter ones, but the larger ones are also increasing in frequency. So there's a true incidence increase, I think. Another important thing to consider is that when you compare the overall prognosis in terms of survival of pancreatic tumors to tumors from other GI sources, when it comes to neuroendocrine tumor sources such as the appendix or the stomach, pancreas, in fact, does tend to overall fare a little worse. The trends have improved over time, and it's not just explained by the increased incidence of very small tumors, causing a shift in the staging shift, but as has been shown by the SEER data here, we can see when we compare the overall survival outcome, multivariate survival analysis using covariate analysis, we can see that distant pancreatic neuroendocrine tumor survival data has also improved, and it's not just then down to tumors that are lower grade and lower stage. So there has been an increased approval and survival benefit overall. And this is important because it's part and parcel of how we manage these patients. And it's very important, even for the smaller ones that are asymptomatic, that we don't mismanage patients at the outset. Management then really, or the objectives of management include possible cure. We also think about preventing or treating complications. In some patients, we think about controlling symptoms, such as the functional tumor, such as an insulinoma or a gastronoma, or tumor secreting other peptide symptoms that may cause specific syndromes, and prolong and influence survival, of course. Some precautions before embarking on therapy would be optimal control of hormonal secretion. The anesthetist should be alerted. Some patients may need to have somatostatin analogs to control specific hormonal secretion. We often think about carcinoid syndrome for the small intestinal carcinoid. Occasionally, we have carcinoids of the pancreas as well that cause carcinoid syndrome and metastasis as well. But if in doubt, I think we always would treat and err on the side of caution with intravenous somatostatin analog therapy. As I mentioned earlier, we need to be aware of higher grade tumors. So even the well-differentiated tumors with a grade, let's say, of 20% or more, or maybe between 10 and 20%, we need to be a little bit more cautious in embarking on local therapies in these type of patients. So adequate staging and also diagnostic procedures such as biopsies will help us with this prior to embarking on therapies. We need to be also mindful of having a full staging with gallium somatostatin PET-CT preoperatively. This can change the management in up to 20 to 25 or 30% of patients, where it shows additional, for example, lymph node disease or even metastasis to the liver that is not even seen on a high-quality MRI scan. And sometimes it needs to be combined with FDG PET if, in fact, there are some doubts, for example, tumors that are not very vascular, or where there's a mismatch, for example, where there are areas within the tumor that don't show somatostatin receptor avidity. And then how aggressive we should be then with respect to oncological versus the morbidity is another consideration that we need to take on board. Therapeutic management considerations then include both patient characteristics, such as the medical history, of course, the age, performance status, comorbidities, life expectancy, quality of life, the goals of therapy, and functional status. And I think quality of life and goals of therapy will impact also on what Vicente will talk about later in terms of very local therapies such as endoscopic versus perhaps surgery, etc. We also have to consider the tumor features, like I said, the differentiation, whether it's a low grade or an intermediate or higher grade, fully differentiated as well. The disease extent, tumor burden, hormone-related symptoms, presence or absence of somatostatin receptors, and the growth rate or the velocity of growth rate as well. Treatment accessibility, whether we have access to PRT, local ablations, and indeed, of course, clinical trials, an important aspect as well. When we think about pancreatic neuroendocrine tumors generally, whether these are localized or whether they are in fact more advanced, we have think about surgery, endoscopy for local therapies. We'll talk about that later. Somatostatin analog therapies, of course, are the mainstay for more advanced disease or non-curative surgeries, lanreotide or octreotide, and they're used for symptom control, but also for anti-tumor effects. And there's a higher level of evidence for lanreotide and pancreatic neuroendocrine tumors, but also we have both octreotide and lanreotide that are used for all GI NETs really, and even extends into lung neuroendocrine tumors now. Targeted therapies such as everolimus and sunitinib are also used and approved in anti-tumor effects in PNETs, but there's new data in GI and lung NETs as well. Chemotherapy may be used in G1 and G2, well differentiated, and some higher grade tumors as well, streptozotocin 5-FU, doxorubicin and streptozotocin, temozolomide, capecitabine, and there are other newer agents as well. PRT, of course, peptide receptor radionuclide therapy using lutetium-labeled somatostatin analogs has been shown to be very effective in pancreatic neuroendocrine tumors, as it has also in the small intestinal neuroendocrine tumors. Is usually reserved for second-line therapies or sometimes third-line, depending on the organ, the pancreas in particular. So overall, we've seen a multidisciplinary shift in the management of NET, and this is just a representation to show of similar time frame between the median survival of time patients is estimated up to there's a threefold longer median survival time in centers that have multidisciplinary approach to management as opposed to a unicenter approach when we compare historical SEER data to a multidisciplinary approach. And this has led for the European Neuroendocrine Tumor Society to evolve and develop the Center of Excellence Initiative. And now we've got 68 European and worldwide NET centers working using very similar models and approach to our patients with endocrine tumors. And this has proved to be very, very valuable in practice. When we look at pancreatic neuroendocrine tumors, then we have to remember also that surgery plays an important role. We can see here for patients with localized disease that the progression-free survival and overall survival, look at the overall survival is up to 20 years and a 10-year survival of 75%. So it's important that we not lose sight of surgery and its role in these patients, especially with a localized stage disease. This is another two trials showing patients with stage 1 disease and cumulative survival probability of 1 on the right-hand side here, very, very good. But as the stage, of course, increases, we see that survival probability decreases. So we have to get it right at the start. And that's why, as endoscopists, we need to get off to a good start when we're seeing these patients. There is a body of evidence for these non-functional tumors that are small and incidentally found, and we'll talk about that with Vicente a little bit later, is that surveillance versus surgery. And this has evolved now over time. The European Neuroendocrine Tumor Society has recommended surveillance in small incidental tumors that are non-functional for less than 2 centimeters. And of course, these are surgery could be then carried out during surveillance if the tumor increases in size. We also have NCCN guidelines that talk about a cutoff of 1 centimeter. The Nordic group has also a cutoff of 2 centimeters. And there are the proponents then for surveillance is, this is one of the French groups just showing that the growth rate or the velocity in terms of tumor size, in fact, is not very high over a number of years. So the vast majority of them are very, very slow growing or not growing at all. There are, however, evidence, mainly from surgical series, showing that malignant behavior with lymph nodes is possible in smaller tumors. In these groups, we can see up between 8 to 29% in these selected cohorts. There's also people that would claim that limited concordance with Ki-67 grading on the basis of US-guided final aspiration biopsy and cytology, concordance with surgical specimens only 69 to 89%. There are also from the National Cancer Database some evidence to support that non-surgical therapies was an independent risk factor for mortality in patients with these. But again, these are selected case series. And this really paved the way for an important study called the ASPEN study, or the Active Surveillance of Asymptomatic Small Pancreatic Endocrine Neoplasia, ASPEN, led by the group from Milan, the Massimo Falcone and his co-workers. This is a multi-center observational study where patients assessed for eligibility was 540, 40 were excluded. We have 500. This was the preliminary data published in the British Journal of Surgery earlier this year. So 500 people were enrolled. Active surveillance was in 406. This is site dependent and patient dependent as well. So it's a real life situation. Surgery performed in 94 patients. And in this, in a median follow-up of 25 months, which is with an interquartile range of 16 to 35, there were 3 deaths unrelated to non-functioning pancreatic neuroendocrine tumors. Surgery in one patient in the surgical group had liver metastasis and had progressed. In the surveillance group, which is important, in fact, this is the most important group. And as you can see that the vast majority were in the surveillance group. Only 9 patients, or 2%, underwent surgery during follow-up, increased tumor size in 4 patients, an increase in the mean pancreatic diameter dilatation in 3 patients, and patient preference in 2. So what we can say then is that a non-operative strategy from our preliminary data from the ASPEN seems safe, as only a negligible fraction of patients have an increase in tumor size, and no patients develop distant metastasis during follow-up. I think this is reassuring. Just a little word before we go into the second talk about particular circumstances of multiple endocrine neoplasia and indeed von Hippel-Lindau. MEN1 poses specific challenges both for diagnostic purposes and also for therapy. Diagnosis, we need to combine endoscopic ultrasound with other techniques such as MRI, but also sometimes also gallium PET-CT. We also use cutoffs for approximately 2 centimeters for pancreatic neuroendocrine tumors in this setting. Diagnosis of gastrinomas, which are quite prevalent in MEN1, can be difficult. The vast majority of them are in the duodenum, and detecting small lesions, even difficult with endoscopic ultrasound at time. And the combination of both functional and non-functional tumors, of course, either involved in the duodenum or the pancreas or other organs, makes it even more challenging. And of course, it's very important that these are indeed looked after in multidisciplinary groups. I won't go through the different controversies, but basically cutoff size between 1 centimeter and 2 centimeters is used for tumors of the pancreas, depending on the local guideline. And then the type of surgery then, of course, will depend on what the objectives are and the tumor staging. And we can, very similar to sporadic cases, though, think about local versus larger oncological resections. For further information on that, I advise you to go to the PNETs website, which is good information on that. So the ideal candidates then for maybe local therapy, which include either surgery or endoscopy, would be small tumor size, I think, small to medium at least, with a low risk of lymph node metastasis. I would say 1.5 to 2 centimeters. PNETs uses a cutoff of 2 centimeters. And I personally feel that endoscopic ultrasound fine needle biopsy is good, because if you've got a low grade, that's also reassuring. If the tumors are functioning, I think it's an excellent candidate for therapy, of course, and especially for endoscopic therapy. Predictable node 0 on axial imaging, CT or MRI scanning. And I would also include a favorable gallium somatostatin PET-CT. Predictably low grade, as I mentioned, and easily to locate, to ablate or to resect. So then we can think about endoscopy for patients with higher operative risks and a functioning tumor, for example. But you could also think of it maybe for a young patient with a big sacrifice, for example, something in the head of the pancreas. But traditionally, anyhow, we're still reserving surgery for the younger patient or the low-risk patient. We can talk about that at the discussion. So in summary then, I think overall survival is improving, more treatment options are available, and more treatments are offered. excellent centers have improved outcomes. There's no doubt about that. And these patients should be seen, or at least in association with center of excellence. For small pancreatic NETs, surgery versus surveillance, of course, remained a controversy, but the ASPEN trial that's almost in completion now, I think is given good, solid evidence that a surveillance strategy is indeed worthwhile in some patients, but careful pre-surveillance workup is important. We need to be also cognizant of the therapies of the goals of therapy, and primary tumor resection like to be a benefit even in low risk of lymph node metastasis, and MEN1 poses particular challenges. Thank you very much. Now we're going to take questions at the end, I believe, and I'm going to pass you on to Professor Ulrike Denzer, who is the head of endoscopy at the University Clinic of Marburg. Ulrike is part of the Center of Excellence Neuroendocrine Tumor team in Marburg, and I know many of our colleagues and friends within this group are very active in both sporadic and indeed hereditary MEN1 patients. Ulrike is an expert not only in pancreatic US, but in many aspects of endoscopic therapy and diagnostics as well. Thank you very much, Ulrike.
Thank you very much for the kind introduction. Dear webinar participants, I want to talk about endoscopic diagnosis of pancreatic NETs in the following, and you already heard about the pancreatic neoplasm, the pancreatic NETs being partially functional active and partially non-functional. So I want to talk especially about endoscopic ultrasound. And endoscopic ultrasound is the main essential endoscopic diagnostic tool for the detection of pancreatic neuroendocrine tumors. And these tumors usually present as well demarcated, hypoechoic with a homogeneous pattern, or partially cystic in case of rapid growth. EOS performs the detection of single and multiple lesions, sizing of the lesion, and determination of the distance to the pancreatic duct. This is especially crucial for deciding the surgical procedure, for example, whether enucleation or resection is done. And furthermore, it enables EOS F&B and the differentiation to other solid pancreatic lesions. A meta-analysis of endosonography detection of pancreatic NET analyzed 13 studies and determined the sensitivity and the specificity of the EOS diagnostics, and both was very high and very good. And here you see an example of a metastatic pancreatic neck, and we found several lesions, 2 lesions in the pancreas being the primary tumor site. And now you saw these small lesions with contact to the splenic vein, and now the bigger one here, ecopure, well demarcated, also in a contact to the splenic vein as an example for detection of multiple lesions via endoscopic ultrasound. Another study determined the additional benefit of the preoperative endoultrasound after the imaging had been performed. This meta-analysis included 17 cohort studies, and the imaging used in the studies was essentially the CT scan, the MRI, and the octreotide scintigraphy. The endosonography identified PNET lesions in 97% of cases, and endosonography alone, and that was interesting, identified PNETs in approximately 25% of all cases. This means that the preoperative endoultrasound increases detection of NETs and should be performed especially in cases of suspicion and previous negative imaging. It has to be critically mentioned that in the many centers, the top PET-CT is standard at the meantime, and comparative studies comparing that to endoultrasound are lacking up to now. So in this case, I want to show you the patient showed typical symptoms for insulinoma and had a positive fasting test, but all imaging and also the PET-CT was negative. On endosonography, we found a slightly more isodense, well-demarcated homogeneous lesion of 10 millimeters. You see it here in the measuring in the pancreatic body. And the lesion was not so far away from the pancreatic duct. And on the Doppler, power Doppler, the findings showed a capsular perfusion, a well-demarcated capsule. Anatomically, it was at the pancreatic body, and we had to rotate the scope in the direction towards the superior mesenteric vein to find the lesion. And surely we did an endoscopic ultrasound using contrast in the following, and here you can see the lesion, and the contrast injection is done, and the lesion shows a clear hyper-enhancement typical for a neuroendocrine tumor of the pancreas. And after that, we did a biopsy of the lesion, and it was an insulinoma with a key 67 of 4%. So I would say that contrast and the endoultrasound is the most important additional diagnostic for characterization and detection of the pancreatic NET. These lesions normally present either ESO or hyperenhancing. A German cohort study investigated the contrast endoultrasound and the differential diagnosis of small focal pancreatic lesions less than 15 millimeter. The study was retrospective in design and analyzed over 390 asymptomatic patients with these small lesions. They found ductal adenocarcinoma in 37% of cases, of which over 90% were hypoenhancing. In 40% of cases, they detected NETs, and in 7% metastasis. The NET tumors showed an ESO or hyper-enhancing pattern, and the authors proposed a workup of small pancreatic lesions with contrast endoultrasound followed by EUS-guided biopsy. In the next example of a patient case, you see a very small ecopure solid lesion in the pancreatic body. The patient had presented for examination with a familiar risk of pancreatic cancer. And power Doppler showed perfusion, but no clear capsular perfusion. And the lesion was measured 60 millimeters. In the following, we did contrast endoultrasound. And in the contrast endoultrasound, the lesion was rather hypoenhanced. And in the following, it remained less perfused, not perfused. Thus, we thought it was had to be a pancreatic ductal carcinoma. The patient underwent surgery in the following. Another case of a rather small focal pancreatic lesion detected endosonographically in the setting of a mild elevated CI-19-2 as an incidental finding. The finding was located in the tail of the pancreas and was slightly cystic. And we then performed a contrast endoultrasound also. And in this, we found a slight hyperperfusion of the lesion, or esoperfusion, you can think about that. And after that, the lesion was punctured. It revealed to be a non-functional NET of a grading 1, a low risk tumor. Both cases show that a differentiation by contrast endoultrasound can be helpful, but does not replace for sure the endoultrasound guided biopsy. Data suggests that a more heterogeneous enhancement may be predictive for a malign growth. Here, a series of contrast endoultrasound videos of pancreatic NET was assessed blinded by 9 endosonographers. The analysis included 80 cases, of which 32% were aggressive, defined as G3 tumor or tumor with metastasis. Heterogeneous enhancement was seen in 43%. The assessment regarding tumor aggressiveness showed a positive predictive value of about 70% and a negative predictive value of 98%. In more heterogeneous tumors, it seems that contrast enhanced ultrasound corresponds to less vascularization and more fibrotic remodeling. And now I want to show you another case. In the next example, you see a patient with an insulinoma also. The insulinoma was located in the pancreatic head, very close to the pancreatic duct and the common bile duct. Here the contrast endoultrasound showed a clear hyperenhancement. The lesion is about 2 centimeters in size. The patient was symptomatic, of course. The lesion was biopsied, endoultrasound guided. It was an insulinoma with a key 67 of 4% in the biopsy. Surgical enucleation was done in the following. And this is the biopsy of the fine needle biopsy results. And in the post-operative period, the patient experienced bile and pancreatic leakage due to the close contact to the ductal structures. And here we performed pancreatic duct and bile duct stenting. The patient went well in the following. And the P67 rate in the surgical specimen was 6% then in the end. Concerning US elastography, I want to show only 2 slides. Here, one slide with a meta-analysis of 17 studies. They differentiated benign and malign pancreatic lesions using this technique. And here the elastography had a good sensitivity, but limited specificity in differentiation. And when ultrasound guided fine needle biopsy was added, the specificity also increased significantly, and the data suggest that elastography should be used in addition only. And regarding elastography and pancreatic net tumors, the data are a little bit conflicting. Paper published in 2018 investigated differentiation of benign and malign pancreatic lesions by calculating a kind of 3-dimensional surface representation from the elastographic measured areas. And the so-called fractal analysis showed a significant difference between malign and PNETs. And another study investigated significance of shear wave elastography versus conventional strain value elastography. And shear wave elastography could not differentiate at all, and strain value elastography only pseudotumors in chronic pancreatitis from adenocarcinomas, but there was no differentiation of, between pancreatic carcinoma and neuroendocrine tumors in an otherwise healthy pancreas. So that means that endosonographic fine needle biopsy is a must finally. And in recent years, different US fine needle biopsy needles and fine needle aspiration needles were on the market, and histology needles have been developed, the first generation needles and now the second generation needles like Francine, fork type or shark needles. There are lots of studies dealing with endoultrasound, fine needle biopsy and aspiration, and I only want to show you 2 of them on the question, what should we do, fine needle aspiration or fine needle biopsy? There is a recent paper dealing with the puncture of solid lesions. The US FNB needles had altogether a higher diagnostic accuracy, a higher tissue specimen rate, and the diagnosis could be made with fewer biopsies. And this is in accordance with our experience. And on the question, which is the best US FNB needle, the data situation is not conclusively clarified in the end. And there's a large meta-analysis that was examining the Francine and the fork type needles, compared them to other histology needles and to the fine needle aspiration. And both needles showed a high tissue quality, especially in pancreatic lesions, and clearly superior to the endosonographic fine needle aspiration. And tissue core rate was high with over 90%, and diagnostic accuracy and sensitivity also. And between these 2 needles, there was no difference. Concerning the pancreatic net tumors, there were 3 studies comparing endosonographic fine needle aspiration with the biopsy needles with the post-operative surgical histology, and here the US FNB was significantly better, correlating to key 67 status and to the tumor grading. And the most data examined the 22 G needles and only 1 the 25 G needle. And so I want to summarize that with the following statements. Endoultrasound is superior, especially in the detection of small pancreatic nets, and studies comparing it with glutathioc PET-CT are lacking. Contrast endosonography provides a good differentiation, especially for isodense and echopoor small findings. In case of hyperenhancement, it seems to be that ductal adenocarcinoma can be largely excluded. Elastography for differentiation and delineation of pancreatic nets still needs more data and provides controversial results. And in case of doubt, endosonographic biopsy is absolutely required and standard. And here, as in other solid lesions, the endoultrasound fine needle biopsy needles are clear superior. Thank you.
Thank you very much, Ulrike, for a very succinct and detailed discussion. We have some questions. We'll save them for the end. And just to remind our audience and friends and colleagues, if you have any questions, please submit them through the questions and answer chat, and we'll get to your questions at the end. We'll have time for discussion. Thank you again, Ulrike. So now we're going to move on to a very interesting talk by our friend and colleague, Dr. Vicente Lorenzo-Zúñiga, who is a consultant in gastrointestinal endoscopy and associate professor at the University Hospital La Fe in Valencia. And of course, Vicente is a member of the governing board of the Spanish and European Societies of Gastrointestinal Endoscopy and the ESGE, of course, and it's very keen pancreatic and biliary endoscopist, but also involved in a lot of endoscopic therapies throughout the GI tract. Looking forward to your talk, Vicente. Thank you very much.
Thank you so much, Dermot. Thank you for your kind presentation. Good evening, everyone. So let's go. To start with my presentation, I think we should answer this question: why we talk about the endoscopic therapy for these pancreatic neuroendocrine tumors? Because from the curative perspective, the surgical approach is the best option. And we have to take in mind that small tumors are ideal candidates for enucleation or pancreatectomy. And in the last years, the size of these tumors has decreased significantly. So, but we have to talk about the endoscopic therapy because surgery is associated with significant adverse events. Most of them are secondary to fistula, so it's for that we have to manage another options. Also, we have to talk about the endoscopic therapy because elderly candidates, high-risky patients that are unfit for surgery, and also because a small lesion is sometimes or many times is very difficult to detect at surgery. Is for that the surgeons require our help to mark preoperatively these lesions. Most of them are insulinoma, to mark with tattooing to detect under direct view, or with to implant fiducials to detect with intraoperative ultrasound. Regarding this endoscopic therapy in these tumors, we have to take in mind which are the challenges we have. And the challenge we have, I think, can be this. First, which are the knowledge and skills we need? The second, which are the tools we have? And finally, which are the complications and long-term results we obtain with these techniques? Starting with the curriculum, the knowledge and skills we need, according to the recent ESGE curriculum positioning statement, to perform these techniques, you should be, or we should be, a dedicated pancreatobiliary endoscopist with a room equipped with both endoscopic ultrasound and fluoroscopy. And regarding our skills, obviously we need an important clinical experience with a volume of higher than 250 cases, including more than 75 biopsies. And regarding our skills, we should be able to detect the anatomical landmarks and accuracy within a high percentage of our cases. So we should be experts. Regarding the tools we have, I think these are the techniques we have to talk. Starting with the prior to surgery, we can use the tattooing or fiducial implantation, and from a curative intent, or we have to talk about the ethanol ablation or radiofrequency ablation. The problem with this technique is we have a very low experience, and so many published cases are a small case series, so it's very difficult to obtain robust conclusions or robust data. But I'm going to show you which are the evidence we have with this technique to select the best one. Starting with the tattooing, we can mark these lesions. We can mark the normal parenchyma. For example, if we are working, we want to mark the tumor located in the tail on the pancreas, to landmark the resection of the lesions, or by contrast, we can mark the tumor, for example, is it located in the head. But if we analyze which is the experience we have with this technique, in this slide, you can visualize which is the summary with the tattooing. You can confirm the number of patients is not very high, it's a small series. We can use different solutions, different volume, but what is true is the efficacy. If you perform the tattooing, the surgeons can detect the lesions and without adverse events. So it's a very good alternative when it's necessary. Regarding the fiducial implantation, we use fiducial in this case to guide to surgical resection to detect the tumors. And this technique obtained an important technical success, around 90%. We implant 3 to 6 fiducials with a needle 22, 25, and the results are comparable with tattooing. So, but the problem is the experience is low. But it's a good alternative in some cases. Yeah, but starting with the real therapeutic endoscopy, we have to start with ethanol ablation. And as you can see, this is the experience we have with ethanol ablation. The series is a small case series with different type of tumors, functional tumors, non-functional tumors, different size, different efficacy, different adverse events. And regarding the technique, it's very important to advance the needle to the center of the tumor. Then we inject the ethanol. It's a heterogeneous concentration, different concentration, with or without lipiodol, with or without contrast enhancement. The most important is to avoid to retain the normal parenchyma to reduce the risk of pancreatitis. But if we want to analyze the overall efficacy of ethanol ablation, we can differentiate functional versus non-functional tumors. And as you can visualize, is heterogeneous data with different concentrations of ethanol. Most of these tumors are sporadic. Regarding the volume of the solution we are using is less than 2 millimeters. And the size, the mean size of the lesions is around 13 millimeters. But if we analyze which is the efficacy, okay, you can observe patients with functional tumors, we obtain a higher complete response, 94%. By contrast, in patients with non-functional tumors, we obtain 62% of complete response. We define complete response when in the follow-up, for example, 1 month after the technique, we do not detect an enhanced area, for example, with a contrast CT scan. But the problem with this technique, we can induce an important percentage of adverse events, around 31%. The most important are pancreatitis and abdominal pain. So we have to manage, we have to reduce the risk of these adverse events. Perhaps a good option is to think like an ERCP, to administer a rectal indomethacin, to administer hyperhydration, renal lactate, etc. If we talk about radiofrequency, we use this technique to induce coagulation necrosis in the tissue. I think, to my knowledge, we have 4 different probes on the market to induce this hyperthermic injury or coagulative necrosis. I think they can be comparable. The main difference is the length of the active segment, 5, 10, 15, 20 millimeters, because this is very important to select the proper one according to the size of the tumor to reduce the risk of adverse events. Regarding the technical aspects, the extension of the ablation is different according to the power we use, the duration of the power, or the application of the potency, or the procedure, the length or the type of the probe. It's very important we advance the needle into the lesion with avoiding major vessels. It's very important we confirm the tip of the needle in the margin of the tumor. Then we start with the radiation, and we have to stop when the bubbles appear to reduce the risk of pancreatitis. And then we decide to repeat a new passes in this season or in next seasons. But if we, obviously this is the technical aspects, but if we analyze which is the long-term results and complication, adverse events, if we visualize the first cases from 2014, 2019 with 70 patients, obviously it's a heterogeneous population, functional, non-functional tumors with different size, bigger size in non-functional, small size in functional tumors. But the ranking of the efficacy is between 70 till 100, but the adverse events, the percentage of adverse events is better than with ethanol ablation. If we base it on this case series, we can identify which is the best predictor of response, and the best predictor of response is the size of the lesion. Lesions less than 18 millimeters present a better response. Is for that, radiofrequency could be a very good option for the small functional neuroendocrine tumors unfit for surgery. If we analyze the last series with more patients, no more patients, 14 patients, the complete response rate is around 85%. Obviously, it's bigger in functional, it's lower in non-functional tumors, but the risk of adverse events is lower, around 13%, using prophylactic indomethacin, hyperhydration, etc. The objective with radiofrequency with functional tumors is to obtain the early relief of symptoms. By contrast, with non-functional tumors, we can induce more adverse events because it's more difficult to obtain a more complete ablation, so as compared with functional tumors. So we have to decide which is better, a partial ablation to downstage the stage of the tumor. So this is a question we can discuss. And regarding the algorithm, the protocol, I think it's very difficult to propose a solid protocol based on our very low clinical experience. But to be practical, I think we could recommend endoscopic therapy for patients unfit for surgery and when the tumor is easy to locate. And if we separate functional tumor, non-functional tumors, in functional tumors, I think we have to administer endoscopic therapy. I think radiofrequency first and ethanol ablation. By contrast, if we decide what we have to do with non-functional tumors, the size can be important. For example, in tumor less than 2 centimeters, I think follow-up is a good option if we are sure the patient has no risk of tumor progression, perhaps based on data from mitotic index or signs of distant spread, because if we find any risk of tumor progression, perhaps we have to administer endoscopic therapy. By contrast, patients with bigger tumors, non-functional bigger tumors, the question is to therapy or non-therapy, because the we have to consider under treatment versus over treatment, the risk of adverse events, and which is more important, to obtain a complete ablation or just to reduce the stage of the tumor. And finally, in conclusion, and we have to say that regarding the endoscopic therapy, that most of the publications are experience of a small case series. The great advantage of the endoscopic therapies can be easily repeated if we consider necessary. The lesion size less than 80 millimeters is the best predictor of response. Radiofrequency seems more efficient in functional pancreatic tumors, and in non-functional pancreatic tumors, we can produce more adverse events because we are going to need more complete ablation as compared with functional tumors. Thank you so much for your attention.
Thank you very much, Vicente. This really was an excellent talk. And thank you for joining us back again, Ulrike, for the discussion, which we can open now. And please be free, my colleagues, to ask questions as well. There was a first question that was about just a general topic. I'm not quite sure. Where can we find the registration of the event? So I think this perhaps is referring to the ESGE days. If that's the case, please just go to the ESGE website. It's very simple to follow and look for the up and coming registration and also for the abstract submissions. I'll show you a little bit on that again, I think, in the closing slides. So a question for the talk then for you, Ulrike, please. So it's from Francesco Vitali. Why did you perform FNA of the insulinoma if the fasting test was positive and imaging was suggestive for insulinoma? Surgery in this case was mandatory, independently of the results of FNA or not.
Yes, you're right. I showed two cases. In the one case, the imaging was not so clear. We had to find the lesion and especially the localization of the lesion in the pancreas. And in these cases, our surgeon like us to have a biopsy because they want to know that it's really the right lesion they are searching for before they do a resection or open surgery. In these cases. In the second case, the insulinoma was rather seen in MRI scan or PET-CT, and we did confirmation endo ultrasound and using contrast enhanced. We do regularly biopsy of these lesions. We should have. Probably it would have been a possibility to do it not in this case and to say this is the lesion and it's all fitting together and the patient goes to surgery. But we think that AOS-FNB is not such a dangerous thing and our accuracy rates are very high and the patient feels a little bit better before going in a surgery if we can say, okay, the lesion, the histology is an insulinoma, it is in this place and it is confirmed, and therefore with a low complication rate, I don't mind doing an AOS-FNB in this case. Is also perhaps other centers do it another way, but I think it's not so dangerous, and the patient is confirmed that he.
So the complication rate, I think, from published data is 1 to 2% pancreatitis, and okay, it's not so big. One of the difficulties, of course, if you have a pancreatitis, it could ruin the chance of surgery for the patient going forward. I personally don't. If it's a diagnostic, if it's definite insulinoma and you find it easily, either in a CT scan, sometimes the surgeon wants to have an EUS because they want to be definite of the localization with the pancreatic duct to make an enucleation sometimes more feasible. If it's definite on EUS and is only a single lesion, I fully agree with it. I don't do biopsy, but I think really important is when you've got these difficult to locate lesions and you're not sure. Mm-hmm. And your confidence is not so high. It's only 80% or something like that. I think this can be very useful to biopsy. Vicente, you have a comment on that?
Yes, I agree. I think yes, I agree with you, Ulrike. I think yes.
Okay. There's also a question about for you, Vicente, about the recommendation for follow-up post-RFA for pancreatic NETs. So what is your proposed follow-up? If you take a patient, let's say with an insulinoma, and you do the ablation, how often, by the way, how often will you have to, how many times will you have to ablate, first of all? And then what is your proposed follow-up protocol?
Okay. Regarding the follow-up of patients we have performing ablation, we have to differentiate functional versus non-functional tumors. In functional tumors, to confirm the clinical efficacy by the relief of symptoms, this is important. In non-functional tumors or in functional tumors, we have to perform 1 month after the therapy as a contrast CT scan to confirm or not the complete ablation. This is important. And then we can decide a new season or not. In lesions smaller than 15 to 10 millimeters, I think single season is enough. In lesions bigger than 15, 20 millimeters, perhaps we have to repeat. I think it's much better to go step by step. It's much better to reduce the risk of pancreatitis, not to try to solve all the tumor in a single season. But the problem is we have not enough data, but we have more robust experience.
Okay, and then I suppose also with the defect, and we mentioned this before, with regard to the actual defect that you're following, it could be a little bit cystic or necrotic looking. Well, I suppose in a functional patient, you know from the symptoms and maybe also from the tumor markers in some cases. But if you extend RFA to patients who've got high risk of surgery with non-functional tumors, let's say a little bit larger, it may be possible as the experience with this technique improves over time. A careful protocol follow-up may be more difficult, of course, to adhere to. And one, I suppose, a comment also is that, you know, if radiofrequency ablation and other techniques improve, why not also use it for non-functional tumors in patients who have to undergo surgery for, you know, big sacrifice of surgery for head of pancreas resection, etc. So, I mean, we talk about the not fit patient for surgery with a functional tumor such as insulinoma. So it's an elderly patient with an insulinoma. It's a great candidate, of course, for RFA. But I think with time, it could be extended to other indications. Do you not agree?
Yes, sure. Sure, because at the end we have to, I think the great advantage of these techniques is we have to separate complete response, complete ablation and this is with a curative intention versus palliative intention to reduce the downstage of the tumor, to reduce the risk progression. Perhaps is another indication of these techniques to reduce the risk of tumor progression in more advanced lesions.
And I think it also shows that the vast majority of groups that are looking at this have got very close harmony with their good quality pancreatic surgeons as well. So it fits into a multidisciplinary approach. Excellent. Ulrike, there's another question for you from Davorin Serrani. Which needle do you prefer for pancreatic neuroendocrine tumors?
I generally work at the current times with the 22 gauge Francine needle. I use it for every biopsy, pancreatic lesions, but other lesions also. And I think we have a very, very high output with that. I'm very content, and I don't do cytology. I do histology only, and I put the whole needle biopsy specimen in formalin completely, and our pathologist can work with that very well.
So you don't do rows, you don't do rapid on-site?
No.
I do the same as you, but I make one slide from just a tiny bit of the fragment. So I take out and I put all of the fragment into cytolite. We just make one slide to see that it's representative. That's what we do, but different people have different techniques.
Yeah, different. We do all in formalin, and it's working. And in Germany, rose is not so used.
Cytolite, okay. And you, Vicente, you with biopsy?
Yes, the same as Ulrike. The 22 needles I think is the best. I think because we can obtain enough sample to analyze the mitotic index and the receptor or somatism receptors. Yes, the same. I think it's
And in formalin or cytolite?
sorry.
Do you use formalin and wrap it on site or not?
Sometimes, not every day.
And you put it in cytolite or formalin?
Formalin.
Formalin. Okay. Okay, that's very good. There's a question then, I think, for you also, Vicente. Is recurrent hyperglycemia, but a negative contrast enhanced CT scan, how do you proceed? Do you do a gallium or an EUS? Maybe I mean, I think that here this is a bit difficult because.
Oh, yes.
Yeah, I don't think the gallium dotatate or gallium PET-CT for insulinomas is not always very positive because of the lack of somatostatin receptors, number one. So somatostatin receptor imaging in insulinoma, unless it's malignant insulinoma, tends to be quite low. That's the first thing. So if you think you've got somebody with recurrent hyperglycemia, but your scan is not showing any contrast, let's say, what will you do?
Oh, that's a good question. So because we have to suspect the insulinoma, we have no image that confirm the location of this tumor. So, wow, perhaps
presumably there's still some active secretory tumor cells at the level of where the ablation took place.
But we cannot ablate if we are not able to detect the tumor. So perhaps we can use an enhancement, endoscopic ultrasound with enhancement, with contrast to detect the lesion. Yeah, but we cannot perform therapy if we are not detect the tumor.
So contrast enhanced might be useful to try to localize a small bit of ongoing viable tumor, perhaps to retreat, correct?
Yeah.
Okay, not a very easy one, of course. And we've covered that in terms of follow-up. Ulrike, I have a question for you, and you showed one tumor that was partially cystic, but what about true cystic pancreatic NETs? First of all, how can you suspect them from in a non-functional cystic pancreatic NET? Are there any clues? And do you always biopsy these as well then?
Yeah, if a cystic pancreatic tumor occurs, we have several differential diagnoses from IPMN, solid cystic lesion, and to cystic NETs, and it's not so easy. I think we have to biopsy in the end to get a real diagnostic result. I think you can do contrast ultrasound, but it helps a little bit, but it's not a complete final result. I always take a biopsy.
Yeah, so do I, and I think that sometimes when you see a little bit of a thickening in one part of the cyst, like a small lemon-shaped rind, that can be a clue. But of course, biopsy is often positive in these patients, I find as well. So it's quite useful. Okay. Have you any questions? Oh yes, there's a question for tattoo. Do you inject Indian ink, Ulrike or Vicente?
No, I don't. I just asked my surgeon what they think about doing these fiducial markers. But they say, okay, if you say where the lesion is, we find it with using laparoscopic ultrasound within the operation, within the surgery, and they're not so keen on me to do that for them. And I don't use ink then. I thought about doing this placement of the markers.
Yeah, I mean, I haven't done it either because I work very closely with my pancreatic surgeons. Usually they believe me. And I also think that when you describe something and you're confident about it, it's all got to do about being comfortable with the group you're working with, I think, number one. Vicente, do you have any comments? Do you use the markers?
Yes, instead of tattooing, we prefer the fiducial implant because it's easier, it's much better to use intraoperative ultrasound. But I think regarding the type of solution, if you analyze the evidence, is heterogeneous, okay? But it's different volume, different solutions.
Okay, and I think that certainly the gold markers can be used, and I think that they're used in some groups as well. And finally, can I ask you, Vicente, also a comment You spoke about ethanol use for cysts, ablation of cysts. Of course, there was a big vogue and hope that this would be a very useful form of therapy. You take the aspirate, you make the diagnosis, and then you inject some ethanol. Because of the risk and also I think the complete response rate of only about 60% and the risk of pancreatitis, should this now be abandoned completely? Yes, we all agree?
Yeah.
Okay. So I think that's an important take-home message as well, because maybe there's some of the solutions down the line that will be considered. We have another question then, finally, very last one. Maybe I can address this. Enucleation of a pancreatic tumor versus resection, when to consider. It's slightly outside of the remit of this talk, but of course this is for a surgical to consider. So enucleation would be for something generally small tumors, functional or non-functional, it doesn't matter, but that are predicted node negative, of course, and in a favorable site. So we think of enucleation for obviously insulinoma patients, so pancreatic sparing surgery, which would be very good, and resection then for larger tumors or in areas where you can't offer patients simple removal of the tumor, such as enucleation. And that would be when tumors are sitting right on the pancreatic duct or maybe deep in the midhead of the pancreas. But more and more now, even in the uncinate process, we can perform uncinate process resection or limited resection, even of the head, etc. Where possible for small lesions that are not predicted to have lymph node involvement, we can try to spare resection. And of course, this is where really Ulrike's comment is so important. If we're going for limited surgery or limited ablative techniques, such as Vicente or RFA or whatever we're using, we have to be confident that there's no higher grade within the tumor. So that's where the biopsy will bring you a lot of confidence, especially for limited techniques. Would you all agree?
Yes.
Yep.
Okay. I think we've probably gone over time, and we've addressed most of the questions, and it just remains for me really to on behalf of the GSG subgroup to thank both Ulrike and Vicente for giving your time and very excellent talks and participating in the discussion. Thank you very much, both of you, for that. And just also to say that the ESGE is growing, and there's a big partnership with so many different individuals, general gastroenterologists, and dedicated endoscopic personnel. So it's a big family. Please don't hesitate to join. There are lots of benefits, of course, for joining the ESGE. Just also to remind you that there are grants, for example, within this for the younger group, research grants open to applications, and the deadline is approaching November the 30th, so still a little bit of time. And you can find this on the ESGE website. Thank you. And I'd just like to also just to remind people again, once again, about the ESGE days, closing date for the abstracts and closing date for registration coming up. So join the ESG website to find more about that. And thank ESG, the governing board, of course, for providing us this opportunity to have this webinar. To thank Gabriela as well, Varga, who's been our leader in terms of setting this up and doing a lot of the work and the communication, and David Inca, who provided excellent help in terms of the logistics and the IT with respect to this webinar team. So very good evening to everybody. Thank you for participating, and we look forward to meeting you again in Dublin live or on a hybrid, and again in other webinars down the line. Thank you, Vicente. Thank you, Ulrike.
Thank you.
Thank you.
Thank you so much.
Thank you very much.